Michael, hi, how are you?
Jaime, long time. How are you doing?
Yeah, fine. It's good to see you after finally we did the right count, and this is our 25th program. Unbelievable. I know you've only done half, 22 and a half, and
12 and a half.
22 and a half. I mean, what did I say?
12.
Um, 12 and a half.
Uh,
But, well,
but
it's a
it's
great pleasure
22 and
to
a half. Jaime, it's 22 and a half in pesos.
have. It's $1.
Yeah.
No, listen. Welcome everybody. This is a very special program where we want really to make a full resume of this crazy year, and we also want to give you some information on how the program has been going from the very beginning. This started as a real exercise on something. I don't want to say communication because I mean it has a lot of ways to be looked at. Don't you think?
I think what you have done, Jaime, and I give you all the credit here, you have put together a phenomenal cast of dentists with a lot of insight, a lot of experience that they share their views and the research with everyone who has checked in here. I think what you've created here, Jaime, has been a tremendous resource to our profession as a whole. Congratulations. Seriously, I
No,
mean that.
no. I know you do, but I think I look at it as something that we've built together. In many ways. Maybe yes, the original idea of having a space called so crazy, starting by a crazy name and following by a different format, which I think we'll get to everything. But first of all, I want to remind everybody that both Michael and I have appeared through all this year in a pro bono way. We don't get any kind of honorarium. Neither any of our speakers did. And wow, Michael, you brought a very solid group of scientists and dentists from many parts of the world. I know some, but I was amazed at your insight on all these people that were never heard by the Mexican audience. And now this is not a Mexican audience anymore. We have people from Central America, from South America, some people in Europe, in Asia, in Europe, because we keep it on demand. So sometimes we people were not able to see it live. This is a full live program, but they were able to watch it the day after or a few days after. By the way, you must be freezing. It's 1 degree Celsius in New York City.
We are expecting a lot of snow.
So it's going to be a white Christmas
If
on
it
top of,
stays, I think it's going to be a lot of rain after this, unfortunately. But there's probably a white Christmas somewhere.
yeah. No, well, I remember in the years I was in Connecticut, the first year was so cold in Connecticut that there was hardly any snow. That's the year where right after the blizzard that brought down the roof of the Hartford Civic Center, and it was
I think
very
it was
very cold but no snow.
1977. 1977?
That came down on the winter of '78, which is February '78, and then the following year it was a very cold year, but there was no snow. I was eager to do that. I didn't know what it means really to pale snow to get to your car. You didn't have the starters like you have now. You would need a spray to put it in the place where you put the key or a lighter, and you had to burn your key in order to get it go through the ice. Nowadays you just get close to the car and the car opens. You can even start the car before you get in. But no, back those days everything was. And I had a very small Ford Fiesta. The Fiesta has been with me everywhere I go. It was funny. They make fun of me because I was Mexican and I had a Ford Fiesta. But anyway, we also want to thank all our supporters. Many companies have gone through the program, but some have been from day one, and it's a great moment to thank them because otherwise we wouldn't have this nice production that we have week after week, and that helps us also pay for the translation and all the work that it's done during the week. And I want to thank Colgate Palmolive Mexico for their support through the year. Also, Fast and Sharp, a new way to buy dental supplies in marketplaces in Mexico like Amazon or Mercado Libre. And I also want to thank Ideas Dentales, which is a company that up to a year or two, they were only selling mainly to dental technicians. And now they're full into trying to supply, especially digital products to dentists. And they've been very kind through all this year to let us do this exercise. Anyway, I think we're going to go to a video and then we'll come back with some of the numbers of the year. Don't go away.
Observa el estado de la salud de la cavidad bucal mediante la detección de actividad bacteriana de una forma más clara, sin la necesidad de utilizar agentes externos. Visualiza placa dentobacteriana activa y no activa. Microfracturas, filtración de restauraciones, caries, desmineralización, valoración de estado periodontal, valoración de prótesis dentales, zonas retentivas de placa dentobacteriana. Auxiliar visual para el paciente. Funciona a través de la tecnología QLF, que incide la fluorescencia sobre uno de los elementos residuos de las bacterias. La porfirina que se revelará en el filtro de la pantalla, marcando un color más rojizo, dependiendo de la cantidad de porfirina presente, lo que diferenciará la placa nueva de la placa vieja, así como las zonas de gran actividad bacteriana. Encuentra esta poderosa herramienta para llevar a cabo todas tus mejores ideas dentales.
Well, I also want to make a small comment. We had a very sad week, actually, the end of past week, where the mother of the president of the Mexican Dental Association, Dr. Manuel Martinez, passed away from COVID precisely. So this is something that is touching us from very close. There were a couple of members of the Mexican Dental Association who passed during the year. Most of them were not probably work-related. And I think that has a point too on why dentists, it's not that we have a better immune system, or maybe yes, there must be some points. But our hearts and our prayers go to Dr. Manuel Martinez family in these hard moments. You cannot even say goodbye to your loved ones. It's part of the very, very dark side of this situation that, on the other hand, brought us together. And you and me, Michael, in this weekly exercise. So I have some numbers, Michael, to show you. Can you please put the numbers up? We had two kind of programs. We have the programs in Spanish, and then we have the programs in English. And as you can see, the total people who have seen the programs in Spanish have been 73,865 people. But the people that have seen that the program exists, that we were able to reach them, goes to 174,350 people. Of course, some of them are the same people because this is a program that goes. In this graphic, we can see every 2 weeks, and we can see that we started with six. The first program, which was part of a Colgate forum, had so far have been seen by 6,793 people. Then the second program, dental schools and COVID, was seen by 8,746 people. And you can see, and of course, when people are getting more and more information, and if you see the end of the graphic, we had also we stopped giving credits because there were only too many credits out there, and every dentist in Mexico that wants to go through the certification process needs to make 50 points per year, and we started to give these points for ADA members because none of them were able to go to their regular local regional meetings that they used to go every year. And then towards the end, no. But you see, there are all these, hepatitis B and C, the digital era, innovation to your hands, women against COVID. So all these were the ones in English and Spanish, excuse me. Now, the next slide, please. The ones in English, there were fewer programs, 1, 2, 3, 4, 5, 6, 7, 8, 9. There were exactly 10 programs in English with a total reproduction of 39,369 people who watched it, and with a reach of 84,670. So you see, in the beginning, we had a lot because, it was something different. But mainly we have, we started with 6,000 people, then a little bit under that, then we went to 37, then we went up again to 45. And it doesn't have nothing to do with English. It's just that, we suppose that many people prefer to either see the program in English if they really can manage it, or don't like to see this or any other program through immediate translation. I know we had some problems in the past, and we invite everybody who is joining us tonight, and put something there in WhatsApp or in YouTube. You can send messages, and you can say, well, I prefer the ones in Spanish. I prefer the ones in English. I think we'll go. And can we go to the next slide, please? So in total, we have reached through this exercise in Facebook to a little bit over 250,000 people in 26 programs. It's an average of 10,000 people per program. And the total reproduction is 113,234 people have watched our videos. Both 80% do it live, and about a little bit less than 20% watch it on demand. Only YouTube alone have had 5,000 people watching. And it's mostly when we open the channel for English, for the direct audio, that people have used YouTube to listen to the program in the direct program. Can we go back to the studio, please? Podemos regresar al estudio. What do you think, Michael? Nice numbers.
Well, it looks like you average almost 4,500 viewers per program. I think that's fantastic. What reach that is, and it's interesting. I always used to say that if you give a prescription to a patient and you give them, 20 pills, so that 20 pills can go to one person or can go to 20 people, right? They can give one pill to each person or something like that. But when you give advice, like we've done here, it just keeps going. There's no end to it. It's like you're on the internet. There are no limits. So all that information we are putting out there, although we have seen 4,000 plus individual actively participating each time we have the program, my assumption is that there are a lot of more people that hear about this, that heard about some of the stuff that have been going on here, and it will just continue for as long as the quality is as high as we have had it until now. And hopefully we'll be able to keep that quality very high.
Yeah. Okay, now we're going to go to a very fast video, then we're going to come back and we're going to see what was the truth in March and what is the truth today. I don't know what you think, Michael. I divided in testing, treating, preventing, and the input, the what COVID has done to dentistry. We'll be right back. Don't go away.
La línea Guard también ofrece soluciones para quien presenta problemas en las encías. El ya conocido enjuague bucal Colgate PerioGuard con clorhexidina al 0.12% ayuda a controlar el nivel de bacterias presentes en boca. Debido a su amplio espectro bactericida, reduce hasta un 99% las bacterias bucales, reduce en un 48% el sangrado gingival y hasta en un 54% la placa bacteriana. No contiene alcohol, tiene un sabor agradable a menta, fácil de utilizar y con altísimos estándares de calidad y validación científica que lo distinguen de otras clorhexidinas. Al enjuague Colgate PerioGuard se le unen dos nuevos productos que complementan y ayudan al tratamiento de las personas con problemas de encías. La nueva crema dental especializada Colgate PerioGuard con una fórmula a base de zinc que garantiza una acción antibacteriana prolongada que ayuda a prevenir la inflamación de las encías, la formación de placa y sarro dental. Ayuda a prevenir el sangrado gingival hasta en un 66.7%. Puede ser utilizada de forma diaria y prolongada, ya que su principal ingrediente activo se encuentra de forma natural en el cuerpo humano. Y por último, el nuevo cepillo dental especializado Colgate PerioGuard, de cabeza compacta, mango ergonómico antideslizante y con exclusivas cerdas cónicas Perisoft ultra suaves con puntas de filamentos microfinos, garantizan la eliminación profunda y eficiente de la placa bacteriana sin dañar las encías. Gracias a su cabeza con anatomía diamantada y componente de caucho, evita traumatismos durante el cepillado. Colgate, siempre a la vanguardia del cuidado bucal, presentó Colgate Guard, la ciencia detrás de tu sonrisa.
Okay. Well, the first time I invited you, Michael, was in March, and you gave a great presentation on testing. And I know you've been doing a lot of programs for people to watch. What do you feel? Where are we standing in testing? The WHO in the first few weeks said testing. Then some countries did a lot of testing. Some countries like Mexico did no testing. What is your how do you see in retrospective all these things about testing?
Well, I think first of all, when we started to talk about testing, we started to talk about testing for the virus itself. And they were very complicated tests. There's something called PCR tests, polymerase chain reaction tests. And then other tests came out. There were tests for antigen testing, which are not as accurate, but they are much cheaper and much faster turnaround time. And the more we test, Jaime, the more we know how many people really are infected. And unless we know how many people are infected, we cannot put in the public health measures necessary to mitigate or slow down what's happening in the community. Then antibody testing started to come out. Now, that gave us another way of looking at of people getting infected, because the antibodies will show if you have been infected previously. So that gave us a very good idea about, all right, some people getting antibody positive, but they've never been sick, and suddenly we figure out that there's a lot of asymptomatic patients that actually transmit the disease. So that give us that information. Today, by the way, as we speak, the Food and Drug Administration in the United States, FDA, approved for the first time a home test. It's an Australian company. They just came out with it. It's a home test. Takes 20 minutes, and it has an accuracy of around 90%, meaning you're 90% sure if you have the disease, it's going to come back positive, and around 90% if you don't have it, it's going to come back negative. And it costs $30. And you can do it as many times as you want, and you can buy it over the counter, and you can get the test results within 20 minutes. So I think when we come to
Is that the
testing, I
same
think
as
we're
the
getting...
Abbott test?
Sorry?
Is that the Abbott test, or Abbott test is
No,
another
it's
test?
it's a completely new test that an Australian company has developed and was just approved by FDA. It's a test you never heard about. No one has talked about this test before, but it was approved today. The Abbott test is a PCR test. And the PCR test is, first of all, it's expensive, and you have to have special equipment and so on and so forth. This test, you don't need it. The only thing you need is you take a measure, you take some virus from inside the nose, and then you actually use your cell phone in order to get the result. So it's very, very different. But it's fairly accurate, and having been able to do it at home without having to stand in line of getting the stuff done, and $30, yeah, it's money, but I think a lot of people will actually spend that money to get the results within 20 minutes. So we come a long way.
So
We come a very, very long way.
no, I know, but we were also talking back then if it was ethical for a dentist to do it, if he would have to report it, to whom he would have to report it. So now that you can buy it in the pharmacy, is it going to be a way of nobody will know if you have it or not? Or because that was a big issue 6 months ago, 8 months ago. At least I remember it that way.
Yeah, so the issue about dentist testing, there are different reasons for it. One reason is that you want to know if the patient is positive, and maybe then you would use different infection control procedures. Maybe you want to know if patient's positive if you're going to have them in the waiting room or not in the waiting room. Another thing is that you want to know if you are at risk. Some dentists, unfortunately, use testing to say, well, if you're positive, I cannot treat you. Okay? So it depends how you want to use the testing. Now, what I think is very important is that you test the dentist, the dental hygienist, the dental assistant, the people who work up in the front desk. Those are the type of people I think you should test on a regular basis. Because right now, we have no idea about transmission in the dental office. Unfortunately, last week, there was a report of a dental hygienist actually spreading COVID in a nursing home in the United States. We don't know much about that information. It may not be correct, but that's how it was reported. So it was a dental hygienist that was positive, and then staff people as well as patient actually got COVID afterwards. So can it be spread in the dental office? Absolutely, no question about it. Is it spread in the dental office? I think it's highly unlikely and very, very rare cases, but it will happen. Because we deal with saliva and we deal with aerosol and so on and so forth. So it will happen, but I think there was another study that came out from the American Dental Association that talked about that all the dentists that have been tested in the United States and have told the ADA about it, it's less than 1% of dentists that have been infected, and most probably they have not been infected by doing dentistry. So
Exactly.
I think we are very safe. I think we're very, very safe, and I think we do very well when it comes to infection control. Can we do better? Yes, always. We can always do better. But this is a different virus. What I'm saying all the time is that you don't need to be scared of this virus, but you have to have respect. You have to respect this virus because it may cause you harm if you get infected.
I had a patient ask me which I thought it was a very intelligent question. He said, okay, let's use the mask and let's keep ourselves from other people. But do we know if something is happening to our immune system by being so covered up?
I don't think it does anything to our immune system but be covered up like this, to tell you the
It
truth.
doesn't become lazy
It's,
when you don't use it.
sorry?
Doesn't become oh, sorry, lazy?
The immune
You know,
system?
well, let me tell you. This is the discussion we always have. You know, Mexicans go, and we can eat in the street. Even, I took you to eat in marketplace in Mexico City, in Coyoacan, tostadas, and nothing happened to you. But you're not the typical American, because the typical American, just by watching the food, gets sick. or gets drunk just by seeing a bottle of tequila. But I mean, something has to do with living in the States and having such clean stomachs, or the whole digestive system. The bioma goes all the way down, so they keep things in order. But as soon as you reach a Mexican taqueria, and I had a teacher who used to do cold. He did cultivate Mexican sauce, to see all the kind of bugs that were in there. In a how do you call them,
Petri dish.
in a petri box? Yes. So it does something to the immune system, because we eat in the same place, we don't get sick. Americans come, eat in the same place, get sick. So is it really something that nothing's there? I don't want to create a conspiracy theory, but I think that people who are very, very covered up, don't they lose a little bit of their response? No, well, I don't know anything.
No.
I just ask the questions.
Well, I can tell you what. We can test that very easily, Jaime. So in that case, let's look at Muslim women who have a mouth covering all the time. Well, let's see and test their immune system and see if they have a less reactive immune system than people who don't. I don't think anyone's going to do that study. but no, I don't think that the mask is going to make our immune system less responsive to other bacteria.
Do they lack
Don't
vitamin
forget
D?
one thing. Vitamin E?
D.
What do you
You
mean?
need the sun to fix vitamin D. Something must happen when you stay inside, no?
Okay, staying inside is a different story. We're talking about masks now.
Yeah.
Okay?
Well, I heard. I meant the whole thing, just not going out. Many people are still scared.
Yes, they're scared. And there is a certain truth to what you're saying. We see, for instance, a lot more people today having asthma that never had before. We see people being more allergic today than before. And it could be because they're exposed to all these pathogens that they used to be exposed to when we had dirtier homes and we ate dirtier food and so on and so forth. No question. I mean, you develop better immunity. But I think saying that the mask will do it and staying at home will do it, maybe, but I don't think it's going to have any great impact in any way, to tell you the truth, honey. I mean, you see it with children. Children that have been brought up at home, or children who goes to kindergarten. Kids who go to kindergarten, they get sick more, but they also develop immunity, very different immunity than if you hold your children at home all the time. So this exposure between people, obviously it has an effect. I don't think the mask is going to do it. I don't think so.
No.
I might be wrong.
I
I
refer
don't
to the
think.
whole thing of being afraid, of not being close to people and using the mask, and I said, I don't know the answer, but I certainly have a friend that I can ask him this question tonight, because he really said this morning, "What's going to happen to us?" I mean, according to some people, I don't know if it's validated science or not. There are less cases of influenza because people don't get not so many people get influenza because they're wearing masks.
That is correct.
So it has of course, if you don't catch it, you don't get it. Some people may catch it and just pass it, but that's what makes each one of us different. But so do you think that this new home test will stop there, or it will go any further
I
with
think it
testing?
would
We're
help
still
us.
talking about that.
Yeah, no, I think it would help
Pardon?
us. I think this is as far as we can go. You have a test at home, it gives you the answer in 20 minutes. I hope it will be more accurate. Instead of 90%, maybe one day will be 98 or 99% more accurate. But my concern with all of these tests is the same as before. And that is, even if it's 90%, that means you have 10% chance of being wrong. So if you get yourself tested and it comes back negative, you still have 10% chance of being wrong, that you still is positive. So if it comes back negative, and then you say, fine, I don't need to wear a mask, I don't need that social distancing, and I can do anything I want because I'm not, then you have to be concerned. So, and that's the same thing with vaccines. We talked about it. The vaccine is not the panacea. It's not like if you get the vaccine, then you can go out and do everything you used to do before. We still have to be very careful in how we transit from where we are now to the new normal, whatever that's going to be in the future.
Yeah. Well, before we go to the vaccines, do you think that we're doing something different in treating? Because I think that's where the big shift was from the beginning, where people, you didn't really know what happened to people, to their some other organs. Everybody was focused on the lungs, and maybe the problems came from from a different. It started as a respiratory virus condition, but then it spread to other things. Young people, particularly losing limbs or a hand, a foot. Do you think treatment has developed?
Yes, treatment has developed. There are many more people that are being treated better than ever before because we understand it better. But we also see people who are being treated who have long-term convalescence. We talk about months and months and months and months of convalescence. There's some people most probably that are never going to be 100% healthy again. We also see some other interesting things. There are a lot of college football players in the United States that now have COVID positive. And they cancel games or they change the games and so on and so forth. And then they have gone and looked at these very, very healthy athletes that got COVID and they never got sick. But now you start to see they have some heart problems, myocarditis. They have some lung problems. And those are problems that are probably going to stay with them for the rest of their lives. So although we don't
do we know
see all the signs and
it's related
symptoms,
to the virus or to the treatment?
yes, no, related to the virus. So although we don't see or see all the signs and symptoms, I think COVID can do a lot of different harms that we're not going to detect for many, many years to come. So this is it's very insidious virus. It's a very insidious virus in the sense that after all this time, we still haven't figured it out exactly. We don't know who's going to develop more severe disease. We don't know what type of signs and symptoms we're going to get. We don't know exactly what medication is going to work for exactly which one. And look what's happening in children with the cytokine storms and different type of inflammatory disease that they have. It's very different. And I think everything comes back to your immune system in a sense that not everyone's immune system is going to react the same way. And a lot of destruction you see in this viral infection than other, it's not the destruction of the virus, it's destruction of the immune system trying to get rid of the virus. That's where you see a lot of the signs and symptoms and so on and so forth. And we see the same thing here. See the same thing here. I mean, think about it. One of the most effective medications they're using today is dexamethasone. Now, dexamethasone is an anti-inflammatory drug, right? It's a glucocorticosteroid. It reduces your immune response. That makes no sense, right? Well, if the immune response is the one that causes the harm, then it makes a lot of sense.
So we still, because I heard from, you hear from friends, oh, I have COVID. And what are you doing? Nothing. I'm home with the Tylenol. So
that might be good enough for most people.
You think so?
For many people, that might be okay.
So there is no cortisone can you prevent something by using early enough cortisone or an anticoagulant?
No. Not even hydroxychloroquine or any one of that stuff. It does not work as prevention or treatment.
Actually, I have a patient who takes it.
Good.
He had seizures, but it's the first time I saw the drug, and I said, "Well."
I have a way of preventing my house from being trampled by elephants. Every day I close the door. I close it very, very hard with a big bang, and I never had an elephant enter my house.
Did you have any giraffe going through the window? No.
So it's working, So
does it work in Africa?
No, so I mean, a lot of people are taking this stuff and they say they don't get the disease, but I don't know if it prevents it. They may not get the disease anyway. So,
can you get sick from that?
There are 10% of people from the hydroxychloroquine that can get some very severe heart conditions from hydroxychloroquine. A small percentage, but yes, that can happen.
So it's not a harmless drug.
No, it's not a harmless drug. But we use it as an anti-malaria medication, and it's very, very effective against certain diseases. But Dr. Trump said it was very effective, but it's not sure that Dr. Trump was correct.
Yeah, and Lysol gargles.
Yeah, exactly. No, injection.
Listen, we're going to go to another short video, and then we'll come back. Because I want to focus on the preventive and the vaccination part, and then we go into dentistry. Are you okay with that? Good. So please don't go away. We'll be right back.
Una boca más protegida con Povidone Oral Gargle, el único enjuague bucal antiséptico efectivo al coronavirus humano. Su composición química al 1% de iodopovidona elimina el 99.9% de bacterias, virus y hongos. Povidone Oral Gargle, cuida tu salud. Además, conoce la línea Radical, antiséptico y desinfectante orgánico de superoxidación. Protección para los que aman. De venta en Ideas Dentales.
I'm checking with the production. Michael, you gave a very, very good presentation 2 weeks ago for us. I know you've done it also, and now it's also on demand if you Google Michael Click in YouTube. But let's see if they can put it on. And it's precisely about people thinking that the panacea is here. Number one, how many people can be really vaccinated per day? Mexico has not even bought the. Well, we start with this one. I don't know if can you zoom. ¿Le pueden hacer un zoom? Okay.
Yeah.
Do you want to explain this?
Sure. So on the bottom row here on the x-axis, you see something called R0 or R0. It's the basic reproduction number. So what it means is that each disease, one person can affect certain number of people. So if you look at the black dot here, which is SARS-CoV-2, you will see that that comes up to around 2.5, which means that everyone infected with SARS-CoV-2 can infect 2.5 other people, or 2 people can infect 5 people. If you look at measles all the way to the right, you will see, for instance, that one person with measles can infect up to around 14, 15 people, which means it's much, much more infectious. Now, what we want to achieve to get the spread of the virus down, obviously, is have a reproduction number or the R0 number below 1. As long as one person can infect more than 1 or 2 more, obviously the disease is going to continue. So that's the x-axis. On the y-axis, the vertical axis, is something called herd immunity. Now, herd immunity is an interesting concept. It means that you need a certain percentage of the population to be immune against the disease in order for the disease to stop spreading. If you look at measles, you need 95% of people to be immune to measles before the whole population is protected. With SARS-CoV, it's around 60%, which means when 60% of the people in Mexico are immune to COVID, the spread of the virus is going to stop, meaning the R0, the reproduction number, is going to go below 1. So this is what we call herd immunity. Now, herd immunity you can achieve by 2 different measures. You can either have natural immunity, meaning people get infected, and if they get infected, they develop immunity, and now they're immune. Another way of doing it is through vaccination. So let's take the United States as an example. We have 330 million people. If we need herd immunity of 60%, that means you need 198 million people to get immune before we can stop the spread of the virus. If you do it only by natural immunity, you're going to have hundreds and hundreds and hundreds of thousands of people dying in order to get 198 million people being immune. So how do we do it instead? We use vaccines. So with the vaccine, you don't need to get infected to get immunity. So with vaccines, you can actually develop more and more people becoming immune. And when 60% are immune, in that case, the spread of the virus is going to slow down or even stop, and we stop spreading the virus. So that's what herd immunity is all about. We need a certain percentage of the population immune to the virus in order to stop the virus from continuing to spread. Measles, 95%. COVID, I think this is optimistic, the 60%. I've heard up to around 70 to 75%. But 60% is a good number. So this article, Jaime, this article you have showed here was an article that was published today in the Journal of American Medical Association. So this is very, very up-to-date information. Cannot hear you, Jaime. Cannot hear you.
I'm sorry.
No,
In measles, children get vaccinated until the age of 12. It used to be.
Yeah, whatever.
Now with this, even Orthodox Jewish groups or other groups that decided not to do any vaccination, that has changed. But in this case, we're talking about you haven't even. Let's say you get vaccinated in January, then you need another at the end of January or the first week in February. They're not really sure if that's going to be good for 3 months, 6 months, a year. So you're probably going to need another one in June.
We don't know. We don't know.
How will that be assessed?
Well, there are different ways of assessing it because when you get a vaccine, initially what you measure is you measure the antibody response. But the
Yeah.
antibody response is going to wane and it's going to disappear after a while. And then you're going to have memory cells. Now, you're going to have two types of memory cells. You're going to have memory cells that are based on the B cell or plasma cells that will produce antibodies. And you're going to have T cells that are cytotoxic T cells. They're called the CD8 cells. So both of these are memory cells. Now, you have to have a way of measuring how much of the memory cells you have and how effective they can respond to a new infection. And that's a fairly complicated way. It's fairly complicated to do, actually. So we don't do that. The only thing we do now is we look at, did people develop antibodies, yes or no? How much antibodies did they develop? And did they develop disease? So now we are saying that this vaccine is 95% effective. Well, that means that if you look at 30,000 people, and that's the group more or less they've done, they have 15,000 get the vaccine and 15,000 don't get the vaccine. And out of 170 people who got the disease, 162 came out of those that didn't get the vaccine, and 8 came out of those that got the vaccine. So there you get the 95%. Okay? It's the 8 versus the 162. But it doesn't tell you anything about preventing, nor does it tell you anything how long that immunity is going to last. Okay? And then every vaccine is a little bit different. The Pfizer vaccine, if you compare the Pfizer vaccine to the Moderna vaccine, the Moderna is probably going to be approved tomorrow in the United States. The Pfizer, both of them are around effective 95%, but the Moderna vaccine may be more effective for people over 65. And much less people get severe disease after getting Moderna than the Pfizer vaccine. Not enough to say statistically significant, but there are trends out there that show the Moderna vaccine is better in that sense. So every vaccine is going to be different too.
Plus the storage is easier, isn't it?
Excuse me?
The storage, because it's another challenge.
What do you mean with storage?
Well, you don't have to store it at minus 70
Oh, I
Celsius.
see. Yes. And the reason is the Pfizer vaccine comes in a lipid nanoparticle, and that lipid nanoparticle needs to be frozen to minus 70 in order for it to be okay. Now, there are other vaccines out there. The AstraZeneca vaccine, as an example. The AstraZeneca vaccine can be stored in a room for a long period of time. The effectiveness is maybe only 70%. But if you look at places like Africa or very poor countries that don't have all the freezers and everything necessary, they will probably get those type of vaccines and not the Pfizer and the Moderna vaccines that needs much colder storage facilities. So the way the vaccines are going to be used is going to be very different.
I'm going to ask the production to put our next. I took a very short sample of your presentation of 2 weeks ago, and that will give you chance to arrange your your TV studio is coming down. Did you realize in the back?
I didn't realize, but I'll put it back up.
Okay. So
If I can.
this is part of a presentation that Michael gave to us 2 weeks ago of herd immunity, because people are saying, it's incredible. It's not fake news, but people take part of the truth, and with part of the truth, they came up with this strange story. So, Michael, if you sorry, if you want to explain this for us again, please. Are you fixed?
Not yet.
Okay, we'll give you a few more minutes. This shows you that this program is fully live. And at least there was no earthquake in New York. but half of the studio came down. So yeah, we're gonna see a very very short video of one of the sponsors, and we'll be right back with Michael.
OrthoGuard es una línea completa especializada para quienes usan aparatos de ortodoncia. Cuenta con 3 productos de uso diario que ayudan a prevenir las lesiones de mancha blanca en los dientes. El enjuague bucal especializado Colgate OrthoGuard, con una fórmula revolucionaria en el segmento de los enjuagues bucales, le proporciona a los consumidores una efectividad terapéutica en el tratamiento ortodóntico y en pacientes de alto riesgo de caries. Llegamos a los espacios irregulares generados por la adhesión de la resina y el bracket, previniendo la desmineralización del esmalte hasta un 58%, libre de alcohol, sabor agradable y de uso diario en personas de 6 años en adelante. El nuevo gel dental especializado Colgate OrthoGuard, con 5000 partes por millón de fluoruro de sodio, ideal para personas en tratamiento de ortodoncia y o con alto riesgo de caries. Revierte 3 veces más las lesiones de caries inicial y proporciona hasta 40% mayor reducción de caries contra una crema dental regular con fluoruro. Es seguro y se recomienda usarlo diariamente, una vez al día durante el tratamiento ortodóntico, indicado para personas de 6 años en adelante. Durante el tratamiento de ortodoncia, los cuidados de salud bucal exigen mayor atención. Los brackets y alambres ortodónticos pueden impedir una buena higiene bucal. Por eso Colgate ha creado el cepillo dental especializado Colgate OrthoGuard, con cerdas multinivel, indicado para quienes usan aparatos ortodónticos. Gracias a su forma en U, cubre toda la superficie del bracket, mejorando el efecto de limpieza en la encía, dientes, alambres y brackets. Las cerdas externas en forma de espiral eliminan la placa dental en la línea de la encía, proporcionando así una mejor sensación de limpieza en los tejidos bucales. Y a su vez, las cerdas internas auxilian en la limpieza alrededor de los brackets y alambres ortodónticos. Sus puntas de 0.01 milímetros pueden limpiar pequeños espacios, proporcionando una mejor limpieza de la superficie de los brackets y alambre. Colgate, siempre a la vanguardia del cuidado bucal, presentó Colgate Guard, la ciencia detrás de tu sonrisa.
God bless commercials. We have you back. Now, can we put the presentation, please? So, I would like you to re-explain this that you told us 2 weeks ago.
Okay, so this is what I told you about the last slide. It's the herd immunity, right? So it's some people call indirect protection because you don't do anything except that other people are getting immune in the community. So what happens is you get protected if enough people in the population has become immune to an infection. And we have known about this for hundreds of years. There's nothing new about it. The question is how many people need to be previously infected in order for the entire population to be protected. So if you take next slide.
La que sigue, por favor.
There you go. Okay, so here is one situation where you have a lot of the blue guys here. They are not immune and still healthy. And then you have 2 people there that are not immune. They're sick and they are contagious. Next slide, click. So what happens now, the contagion is going to spread very quickly throughout the population. And of course, many of the blue guys are now going to be red. They're going to be sick and contagious. All right. So that's normally what happens. Next slide, please. Now what you have some people that are immune and healthy. You have others that are not immune but healthy. Those are the blue ones. And you still have these red guys there that are sick and contagious. So some are immune. Next slide. So in this situation, you're going to still get a lot of people that are going to get sick. Obviously not the immune ones, but some of the blue ones. But you're still going to have some people that are not going to get sick. Some are still going to be immune and healthy because they cannot get sick. And then you're going to have the red guys that are still sick and contagious. So contagion spreads throughout some of the population. Next slide, please. Now you have a lot of immune people. You have, in this case, more than 70% of the people are immune. You have some that are not immune and are still susceptible. And you have these 2 contagious people. Next slide, please. And now what's going to happen is you only get maybe one more person that's going to get sick, not more than that. And this is what you call herd immunity. So the spread throughout the population is contained because so many people are immune that it's very hard to spread it to other people. And that's what I mean by herd immunity. So when it comes to SARS-CoV, we estimate that at least 60 to 70% of people need to be immune and healthy in order to stop the spread of the virus throughout the population. I cannot hear you, Jaime. Jaime, I cannot hear you.
So give us a panoramic of no bumps in between. What can we expect in 21 if or how long do you think it will take for 60% of the population to be immune?
It depends on the vaccines, because natural immunity is going to take a long time, and a lot of people are going to die before everyone is going to be immune. Enough people are going to be immune. So again, in the United States, we need to have vaccine, and we need to have every person getting vaccinated in order for that to happen, because they say that 95% effectiveness of the vaccine. Let's say it's 80%. Let's be more realistic, because we don't know what happens to children. We don't know what happens to people with diabetes and heart disease, etc., 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 etc. Right? So we don't have all of that information. So let's say it's 80%. Now, it seems like not everyone is willing to take the vaccine. So let's say 80% of those 80% is going to take the vaccine. Well, that's 64% of the population. So that means that until we vaccinate the entire population, we're not going to reach that 60% immunity that we are looking for.
But
so how long time is going to? Sorry?
No, it will overlap with the people. It's a continuum. So
yeah, it is. So today they estimate that if we get all the vaccines and there's no problem with getting the vaccine, having the syringes, having the bandages, having the alcohol swabs, having the gloves, if everything goes perfect, we probably can estimate by the middle, maybe July, August, that maybe everyone in the United States will have the vaccine, which is a very rich country that have invested billions of dollars in this vaccine. What's going to happen in the rest of the world? I don't know.
Now, but that's the next question. The U.S. is also a breach of business, of travel, So what do? You vaccinate everybody who comes down of a plane?
It's too late.
Would you buy, instead of first class, you're going to buy a ticket with the vaccine included?
It's going to be too late.
No, I think
You
it's.
need to do it days before.
Yeah, well, but one of the biggest reasons that New York got as bad as it got is because all the people that go through Kennedy Airport in one day.
Yeah.
And you have 3 major airports. Well, 2.5. LaGuardia has always been a small airport. But imagine, so all these nanotechnologies, can't you still make something that you spray and you see where the stupid bug is? No? Wouldn't it be great to paint it?
That would be wonderful. We cannot do that, unfortunately.
I told you a couple of times that maybe medicine is looking the wrong way. We should be checking with magnets or with certain vibration lights or.
So bottom line, Jaime.
Yeah,
Jaime. Bottom line, this is a pandemic. Most probably, it's going to become an endemic. meaning we're going to have it all over the world. It's going to be much less prevalent, and we're going to develop probably better treatment for it. So become a chronic disease maybe, or even some people are going to be healed completely or cured. Immunity, I don't know how long that's going to last. Some people say it's going to last maybe 6 months if you have been exposed. That means after 6 months, you can be exposed the second time and get sick again. Maybe if you get sick get exposed a second time, the disease is not going to be so severe as it was the first time. So we don't have any answer to these questions yet. It's gone too fast, and we haven't. It's not been long time enough to figure this out yet. As I mentioned many times, every 4 minutes there's a new article on COVID coming out. Every 4 minutes. There's no way we can keep up, and there's no way we know if these articles are accurate or not, or how accurate they are. How good of a
I was very,
research it is. So,
I was very upset the other day on your name because in one of the
oh,
groups that I hold, they posted something that has supposed to come was sent to a member of that group by a doctor, by a physician in Cuba. First, he said he works in the only hospital that none of its health providers has gotten sick from COVID, and he did what they did is everybody had to brush their teeth. So they did a study with one lady that had a lot of comorbidities and brushed her teeth, and then another guy who didn't have any comorbidities and didn't brush their, and the lady with the comorbidities didn't have any symptoms because she brushed her teeth. So end of the story is very nice. Two patients, sorry, to compare two patients and said that 50% got better is still very low, just by brushing your teeth. And number two, can you say that there is a place on earth where COVID is present? Because some countries in Asia don't have this, or in Africa don't have this as bad as we have it so far. So
and
maybe in those
now
places
they
there
don't
must
have,
be hospitals with no people sick.
yeah, behind me. There's one reason they don't have it. It's because they don't test for it. If you don't test for it, you don't have it.
No, but they also don't have people dying from it. So
They don't have
maybe.
statistics. They don't have statistics that says that people are dying from it either.
Yeah. Well, some places are very
But
hard to get a
part of
visa.
it, but Jaime, part of it has to do with the incubation period. And we know today that the incubation period is around 5 days. Could be 6, 7 days, but around 5 days from exposure to signs and symptoms. In 5 days, you can travel quite a big distance. Ebola has an incubation period around 24 hours, even less, 18 hours. How far can you get from Congo, some other place, in 18 hours and keep spreading it, right? HIV incubation period 10 years, meaning you get maybe an initial little cold or something that you don't even know it's HIV, and then you are HIV positive for 10 years before you signs a symptom. So the incubation
So,
period makes a huge difference.
do you think in 5 years we're gonna celebrate our 70 years with a with a beer, and people will go back to to the new bars and restaurants of New York City? No, mean I don't want to
Yeah,
get on the dark side, but I think it's very, very, sometimes the dimension becomes humongous.
you're right. We're going to have a new abnormal.
So
It's not going to be a new
so
normal. It's going to be a new abnormal.
so January 1st, don't expect anything great, other than we made it 2020.
Yeah. No, I mean, hopefully, Jaime, we're going to get some very good. Maybe if someone can come up with some very good medication or some kind of treatment, that if you get it, you can get the medication, you don't transmit it, you're still healthy, and so on and so forth. If that's the case, that's fine. I mean, don't forget, until the 1930s and 40s, before we had penicillin and antibiotics, people died left and right, and then suddenly we have this miracle drug, and everyone who got sick got the medication, they were fine, right? So maybe it will be the same thing here. Maybe we can come up with a good type of medication that can kill this virus, and that would be
You remember,
fantastic. And I don't see
you
any
remember
reason why
Johnny
we shouldn't.
Carson?
Sorry.
Johnny Carson would have a favorite. I had it's been always in my mind that the new age, the average age for Americans males is 67 years old, and that's very good news unless you're 66. Okay. So I think that is a it's very let's leave the jokes for a sec. I think it's really a very, I mean, if we don't if life would be unbearable if we could not detach from the fact that this is something that is going to be there at least for 5 years, 3 to 5 years, until you lose, or some people lose the panic of going in planes or to conventions or to exhibits or to whatever. You don't think so? It's not only let's talk about the economic on another day. I think it's really something that I think we got a little, not tricked, but the vaccine is here, and now they tested, and now everything is in real time. Okay, but then all of a sudden, okay, now have a second shot and then wait. Call me back in 6 months.
So I have some other bad news for you. In
What?
Britain right now, they have discovered a new variant of COVID-19 that is even more infectious.
And wait, my computer is getting off. I didn't connect the battery. Sorry. Which means?
Which means this virus mutates, and we might get other type of variants as well. And if you look, this is behind me. This is an RNA virus, and RNA virus is very hard to treat. HIV is an RNA virus. Hepatitis C is an RNA virus. The RNA viruses, when they replicate, they don't have the mechanism to correct wrong replications.
Yeah.
Like DNA viruses, they can sort of adjust and fix when it goes wrong. RNA viruses cannot do that. So that's why we can find a lot of variants. And unless we get rid of it quickly, we might get more variants. We need Batman. We need Batman to come in and help us.
Hold on a sec. We're gonna have a few of the names. We've done. I think we have very, very interesting guests over the year, talking on the impact of COVID in dentistry. And production, can you help us with the slides, please? This is Chalacombe, right?
Stephen Chalacombe, yes. And Eve Cooney.
Cooney.
Eve Cooney has now become the delegate to CDC. She's now part of CDC when it comes to developing the new infection control procedures. She represents ASAP.
They were in us with us. I think this is in April, when we started the Colgate Forum. Next, please. This is a slide from the day we had the Yasmi and John Featherstone to talk about non-aerosol dentistry. Gee, I lost a couple of pounds, Michael.
Who? You did.
I lost a couple of pounds. I didn't have a beer. You had a beer, but look at my chin. Wow. Next. You want to talk a little bit about this one? I think this had a lot of people watching.
So here we had 3 different deans or former deans, new deans. Dr. Lily Garcia is the new dean of School of Dental Medicine at University of Nevada. Linda Neeson was the founding dean of the College of Dental Medicine at Kansas City. They haven't even started yet. The former dean down at Nova. And Dr. Eli Eliav is the director of Eastman Institute, which is a dental school known for postgraduate training. And each one of them have their own ideas about what dental education may look like and should look like in the future. It was very interesting.
I'm going to tell you, Michael, no dental school has opened in Mexico their clinical trainings. Only theory, only home study. None.
So how are they treating patients?
They're not treating patients, and it's sort of extending the year where they're going to do the patients later. And their plans were to start this January, but I'm not sure if they're going to open. Because the COVID is going in Mexico with no control. No, the government has done the worst. I would like to say that they've done the worst they've done, but no, they do many bad things. Next, please. But this is there's no way to control it. This was when we had Stefan Ruhl and Luis Karakowski. We were talking on evidence-based.
Yeah. So Stefan Ruhl is a salivary expert, and he just got actually inducted into the American Academy of Sciences right now, which is very, very prominent. I think there's only 400 members in the entire country. And he is one of them that got inducted this year into the Academy of Sciences. So he's very, very good, and I think his presentation was outstanding.
Yeah. Well, next, please. Gee, just by looking at this, I feel happy that I lost so much weight. This is Dr. Wenke Borgnake, and she's of the Department of Periodontics in oral health medicine at the University of Michigan, and she had an excellent talk on the microbiome.
Yeah, she's very enthusiastic.
Yeah. Next, please. This is
So Perry Dubin, he is a MD. He works at Memorial Sloan Kettering Cancer Center, takes care of a lot of COVID patients with cancer. And Craig Miller, he's a dentist and a virologist, does a lot of research on herpes viruses and other viruses, and they gave an excellent presentation. Perry of the clinical manifestation and treatment of the patients, and Craig Miller of the virology behind the whole disease. So it's a very, very, very good session, that session.
Okay, next, please. Oh, this is we had Violet the first time.
Yeah, I don't know which one this was. That's the one who talked about halitosis, or Perry? Yeah. I don't remember.
No, it wasn't halitosis.
So that's a topic that we don't deal with a lot. Violet has become an expert in halitosis and how to deal with bad breath. something that a lot of patients obviously are very concerned about. But there's very few people actually who has a good lot of knowledge about it, and she does. And I thought it was a very, very good presentation.
Okay, next, please. And this is Sebastiano was great.
Yeah, Seb Adriana has a lot of experience when it comes to implants. He runs the implant center at University of Buffalo, originally from Italy. He tried, I think, to speak a little bit of Spanish, but maybe with an Italian accent. I don't remember. You can tell me how it worked out. But you, as a center that places a lot of implants, Jaime, what did you think about his presentation?
No. I think that just by looking back on how much knowledge was gone through this little window.
Yeah.
This is only the English part. We also have a Spanish part that you're not so aware, because we have to get you a good Spanish teacher. Podemos ir con los videos de español. Okay. You see here we had Eduardo Luis Secotti from Buenos Aires, and Beatriz Aldape from the National University. Both are excellent pathologists. And my good friend Stephanie Chamut, which is a very young Mexican dentist doing public health at the Harvard School of Dental Medicine, doing dental public health. La que sigue. This one, we had a lot of people here because there were the deans of 3 schools. El Barrosa Leiva from the Dean of the National University of Mexico, UNAM. Dr. Aide Gomez Llanos from a very good school in the border with California. They had a branch in Mexicali, another one in Tijuana. She's the Dean of the Dental School in Tijuana. And my very good friend, Dr. Orlando Peniche, who is the Dean of a very, very good dental school in Mérida, Universidad Anáhuac Mayab. Next. This is my good friend Carlos Glad. We had a program on innovation. Next. I really lost my chin. This is a good program that we had on the interaction between medicine and dentistry with Beatriz Aldape, an excellent pathologist and a great teacher at the National University School of Dental Medicine. Dr. Manuel Carrillo, he's my cardiologist, and he has a great program on how to prevent heart disease. And a very good friend of mine from since we were kids, Dr. Mauricio Lisker, who is a internist with subspecialty in hepatology, and he lived many years in Mexico. Now he's for the past 20 years has been in University of Missouri in Kansas. No, University of St. Louis, Missouri. Sorry. Next. This is. We have Resina Casian and her husband, Francisco Curiel. We had a great program on digital diagnosis of CAT scans of cone beams. And then Francisco did a great presentation on how to start planning your cases with the tomography. Next, they live in Seattle. They're both alumni from Mexico. Then they did something at the specialty in the Universidad Continental in Mexico City. And then they went to Baylor, and then some of those talents that stay in the States. Then my good friend Mauricio came back, and we had a program on hepatitis B and C. I think it was a very good program as well. La que sigue. Next. My good friend Enrique Kogan, who is a excellent prosthetic dentist from University of Missouri, Kansas City. He must be very happy because the Kansas City is already in the playoffs with the 12 games, 12 games, the, and one lost in the NFL. Next. This is the program where I got in trouble because I want to say that women are very good by doing things, and then they all jump all over me. With la licenciada Laura Rodríguez, la diputada Congress Lady Cynthia López Castro, which was in a breakfast with her that we started to do the idea of making a law of mandatory brushing. And Rebecca Jones, which is a good actress and a patient of mine. But I got in trouble that day, Michael. You don't know how. Next, please. Then we had something on the what happened to the couple during COVID with la doctora Libe Nurko, a psychologist, and my good friend Dr. Hugo Yofe, was also psychologist and great doing coaching. Next. Dr. Francisco Moreno, which has been the lead one of the best hospitals in Mexico City, the American British Cordray Hospital. And I didn't know him. I just called him one day and he agreed to come. He's really a very, we should do something together with him, Michael, one day, because he's a great guy. Next. Then I have Dr. Antonio Lascano. He's a scientist from the National University. Also, it was an excellent presentation as well. I didn't know him. I just called his office in the National University, and he agreed to come. He had a hard time at the beginning trying to understand my dark side of humor, but at the end it came up being a very nice lecture as well. Next. This is Odín Dupeyron, a good friend, patient. He's an actor, and he's always talking about the good things of life and how to enjoy life and how to live life to the fullest. And he agreed to be with us as well. Next. And this is Dr. Jose Maya Bejar. He is a plastic surgeon, and he is a chair of a foundation that they do a lot of work in labipaladar hendido, of a cleft palate and cleft lip. And it's a multidisciplinary charity where they work with psychologists and periodontists and surgeons and dentists. And they do a great job, in my opinion. Next. Well, this is right after the dental sphere that we had, Michael. We had Manuel Martinez, the president of the Mexican Dental Association, Maria Cam, the chair of ID Academia, and Dr. Sergio Curiel, which is the president of the Education Department of the Mexican Dental Association, to go over what happened at the dental sphere. I think it was also a great thing. And there was one more. Hay una más, ¿no? Yeah. We tried to get something from Buffalo Remember to talk about orofacial pain, but she was not available. So, but I think the subject was very important to touch it, especially now that people are so worried and clenching and doing things they were not doing before, or doing it more often and with more stress. And he's an excellent oral surgeon. Actually, he was the chair of the School of Dentistry that did the program that was accredited by the state of California to do that. Well, Michael, this was a We did it in an hour and a half, but it was a review of a full year, don't you think? I think that if you want to say something about the impact on dentistry, and it's time to let you go to sleep.
Yeah, I think it's far beyond my bedtime,
It's
unfortunately.
past
As
your
you know, I
bedtime.
start,
It's past your bed. But look, my chin. Where's my chin? It's gone.
good for you.
Yeah,
As you know,
yeah.
I
Just
usually
taking this
start my day.
pictures. I'm happy.
I usually start my day at 4:30 in the morning, Jaime. So anyway, well, I think there's going to be a lot of changes to dentistry and the way we practice dentistry. I can just give you one example. 2 days ago, the state of New York will now allow dentists in emergency situation to provide flu vaccination and vaccine against COVID. So we are going to do things we've never done before. It's going to change the scope of practice. Oregon already have a dentist license to provide vaccinations, and other states are following suit. When it comes to practicing, I think the biggest fear of dentistry right now is actually having infected providers. I think our infection control procedures is good. I don't think we need to change very much what we are doing, but we don't have enough data yet, obviously. But I think the scope of practice is going to change to a certain extent. We're going to do many more things when it comes to maybe testing, providing vaccines, and so on and so forth. So that's where I see the big changes in dentistry, to tell you the truth. Another thing that may change, but I don't know how much that's going to happen, is I think there's going to be more focus on reducing aerosol in a dental setting. Can we develop better techniques and different techniques to reduce aerosol? And if not, can we then reduce aerosol spread in a dental office differently? So aerosol, there's always been blood until now, but now aerosol is probably going to be in the forefront, and we're going to see a lot of innovative people coming up with some smart ideas on how to do these type of things. So that's probably what we're going to see in the next year to come. But as far as I'm concerned, I like to forget about 2020, and it didn't really happen, and just move forward and see what happens in 2021.
Okay. Well, we don't have a date. This is the end of the first season. This was the cliffhanger of Genie in a Bottle. We don't know which way we will go in January, but we will appreciate your opinion. Write down if you. There were many compliments for you, few for me. But more than compliment, give us ideas. Give us what you think. Do you think we should continue with this space? Give us a reason to to make a decision, because I can't think of having this success if I hadn't partnered with you, Michael. You've brought many very intelligent people with dentistry in their minds. They were not trying to sell anything, nor a new material or an old material or the same material. They were really people who are worried from the world of science, from the world of the university, which is always has a special focus in education. So you can write to Michael, you can write to me, you can put it in Facebook or in YouTube. What will be, how do you envision Genie on 2021, or maybe this was only an exercise for the 2020? We really don't know. We haven't made up our minds. We have told our sponsors that we have to sit down and rethink. The world is not the same. Although we do have a group of people that write to me, and I want to thank you every Tuesday, every other Tuesday, to thank us for. We always try to bring the best content, try to put our input. It's not only a regular webinar where somebody comes out after somebody in an off voice read a resume, and then you get question Q&A at the end. I think that I try to bring the non-scientific side. Michael has always been there to cover me up when we need the science to push forward. And I really want to thank you, Michael. I don't think there is. I couldn't find a better person to sit with me. Even though we only do English every other week, I enjoy it very much.
No, I've enjoyed it tremendously, Jaime, and thank you for bringing me on board. It's been a great pleasure for me to have the opportunity also to be able to invite these people, as well as, I think, even most important, Jaime, more than anything else, has been questions from the audience. That we can hear feedback not only from what we are doing, but also feedback to make us better at what we do by addressing concerns and questions from the audience and allowing them to have a voice in this program, I think is extremely important. And I think that might be part of how we need to continue. The voice of the audience needs to be heard. And I think we've done a good job, and we could probably do it even better next time.
Let's just remind the audience that you can watch every program from the very first one. Even before we had Jeannie, we started with some lectures on Wednesday at noontime, depending on where you live. And all of those are free of charge. You just go to ID Academia channel and you can see all the programs. Some of them are in English, original audio. Some of them are in Spanish. At the beginning, even the Spanish ones had an English translation. You can just go over. Don't let anybody fool you. You don't have to pay to see our videos. They're completely free. And once again, I want to thank everybody in the production, both Mexico City and León, Guanajuato. I want to thank Maria and Blanca and Erin and Miriam and Santos, and also Samantha, who has been here very loyal every other Tuesday to do the translations into Spanish. Thank you, Samantha. Thank you, Michael. And there's one thing I do wanna say before you leave, Mike. And we're all gonna leave. That the 2030 vision, which is something that we work very hard on, was already approved by the General Assembly of the FDI, and it's going to be presented in January. So we're going to have a special program, a half-a-day program, which in that part we're going to have a lot of information on what the 2030 is, on how for the first time in many years the WHO is starting to see that the mouth and the diseases in the mouth are important, and they're not separated. They should never be separated from the general health. There is no oral health and general health. There's one full health. Thank you very much again, Michael. Thank you very much for you watching, and we'll let you know when we come back, if we come back.
Si te lavas bien las manos lograrás prevenir con jabón y un buen tallado